Good afternoon, and thank you for joining us today. Welcome to the Ear Research Foundation's Hearing Education Series. Today's webinar is Implantable Hearing Devices, When Hearing Aids Are Not Enough. My name is Christina DeFrancisco, and I'm the Director of Communications and Development for the Ear Research Foundation. Today, we are joined by Dr. Jack Wazen, Vice President of the Ear Research Foundation and Director of Research. He will be taking a few questions after his presentation. So now I will turn it over to Dr. Wazen.
Well, welcome to this series, and I was asked to talk to you about hearing enhancement technology, and I thought a good title for this is When Hearing Aids Are Not Enough. Now we're going to go to the next slide somehow. Okay, so hearing is a significant sense in the human population. And as Helen Keller said once, deafness separates people from people. Helen Keller, as you all may know, was deaf and blind, and she wrote a lot about her disabilities. And what she had said is that deafness separates people from people, blindness separates people from things. So it is important for us in the human race to embrace the ability to hear. The hearing system is depicted in this slide here. It is one of the earliest systems to develop in the embryo. And it's the earliest system to develop in other creatures on Earth. So it is crucial in the survival instinct of all animals, and it is absolutely crucial in the communication skills, learning skills, emotional skills of humans. So the hearing system has two components to it. It has the peripheral system, which starts at the inner ear level, and then it enters into the brain where you see it. I'm not sure that this pointer is helpful to them, but so in the brain, as the nerve sends that information from the ear to the brain, there's a part of the brain called the temporal lobe, and in the temporal lobe, that's where the hearing center is. So you have to have a good access from the inner ear through the nerve to the brain to be able to hear and understand what is being said. There are different types of hearing loss. There's something called conductive hearing loss. And a conductive hearing loss means it's a hearing loss where the problem is anywhere between the outer ear, ear canal, eardrum, middle ear system, where the sound is being conducted to the inner ear. So if there's a problem in the ear canal blocking that sound, or is there a problem in the eardrum, a hole in your eardrum, or some scarring in the drum, or if there is a problem within the bones of hearing, where the bones of hearing are not vibrating well, that creates a conductive hearing loss. Another type of hearing loss is called the sensory neural hearing loss, which in casual terms, what people refer to as nerve loss. Nerve loss is when the problem is not in the conductive mechanism of the external and the middle ear, but it is in the inner ear, in the cochlea, or in the nerve conduction to the brain. So those are the two main categories. Is it conductive or is it sensory neural? How do we know that? From your hearing test. And there are ways, as we test you in the booth, to separate whether the hearing loss is conductive or sensory neural. Now, you could have a mixed hearing loss. A mixed hearing loss means you have part of your hearing loss is conductive, part of the hearing loss is sensory neural. And all of this is important to determine right from the start, because what we choose to treat depends on what kind of hearing loss do you have. The hearing loss could also be unilateral, meaning on one side, or it could be bilateral, meaning on both sides. Now, you may have heard in recent news and media and so on how hearing loss has been associated with dementia and cognitive decline and Alzheimer and all of that stuff. So it has become a major source of curiosity and a major source of concern for people who have learned about this as to how much hearing loss is affordable hearing loss and how much hearing loss can cause dementia and aggravates dementia and Alzheimer and cognitive decline. So in one of the studies that was published in one of the major journals in medical literature called The Lancet, which is a British journal, they ran studies to see what are the factors in somebody's life, health, etc., that can affect or delay dementia and cognitive decline. In that study, amazing, all of us concluded that hearing loss in the mid and late life was identified as the single largest potentially modifiable risk factor for dementia. Now, why is that important? It's because it is potentially modifiable risk, which means that if you can modify the hearing loss, you are able to modify one of the risks for dementia and cognitive decline. Some other risks may not be genetic risks. You cannot change that. Aging risks, you cannot change that. But high blood pressure, diabetes, and other factors you can change. But of those that you can change, hearing loss was the most important one. And it's up here at the first curve of that slide that you're looking at. So how does hearing loss create dementia, or how does it factor into the development of dementia? And again, there are multiple theories for that. And the main theory that is now mostly recognized is this theory of what's called a cognitive load. So our brain is used to hearing without effort. You know, a sound comes into the ear, you hear it. You don't think about it, you hear it, you do not need to analyze it. It's in there. When hearing is happening, when hearing loss happens, and the hearing is not immediately recognized at the brain, then your brain now is trying to interpret what you're hearing. It's trying to listen. It's trying to connect items. It's trying to lip read. And all of that creates a load on the brain. So instead of the brain now spending its time focusing on memory and analyzing things that it has to do on a routine basis, now your brain is spending time trying to hear and understand what you're listening to. And that removes or takes away the ability of the brain to focus on other things, including cognitive issues and memory and thinking. So the easier the brain hears, the less challenge it faces in interpretation and in communication. So the first step in managing hearing loss is either hearing aids for the sensorineural hearing loss, or if it's a conductive hearing loss, you could have the option of doing hearing aids or reconstructive surgery. Meaning, if the hearing loss is due to a hole in the eardrum, you fix the eardrum and you fix the hearing loss. If the hearing loss is due to a disconnection of the bones of hearing or to frozen bones of hearing, you fix that surgically and then you eliminate the hearing loss. So a conductive hearing loss is a fixable type of hearing loss. The sensorineural hearing loss is non-fixable and therefore depends on hearing aids. And if we're dealing with conductive, with sensorineural or mixed hearing loss, the hearing aids are the big players here. So the first level of defense is hearing aids. What we're going to talk about today is the cases where hearing aids are not enough, either because you cannot use a hearing aid or because the hearing loss is too severe that you've tried, you've bought a bunch of hearing aids, and still the hearing loss is not helped by the hearing aids. So the first category of implants I'm going to talk about is called the bone conduction implants. And those work for conductive, mixed, or single-sided deafness. We defined conductive and mixed earlier. What is single-sided deafness? Single-sided deafness is when you are deaf on one side and the opposite ear hears well. It doesn't have to be absolutely normal, but it hears adequately well. And that's called single-sided deafness. So bone conduction implants depend on the ability to bring sound through the skull bone, and sound is transmitted through the bone that traverses the bone and goes directly to the cochlea, to the inner ear. And when you get that sound directly into the cochlea, bypassing the ear canal, bypassing the middle ear system, then you are able to hear despite the block. That's for conductive and mixed hearing. When we use it for single-sided deafness, it's again the same principle. If you are deaf on the right side, let's say, and your left side hears well, what the bone conduction implant does, it's placed on the deaf side. Sound is coming into the implant. The implant is conducting the sound through the skull base, and it's going to go and stimulate your good hearing ear at the same time as it's stimulating your bad ear. So it is the good ear that is helping you hear from your deaf side. And that's how the property of implants for single-sided deafness works. So how does this connect? The traditional way for the processor or the hearing device to connect to the bone is through a small little implant. And this is the implant that you see that sits on the side of the head behind the ear. You could see the arm of the glasses here in the bottom side of the screen. And that, it looks like a snap. So a snap could be exposed like this when the hair is very short. It could be all covered by hair. It doesn't matter. So this is the connection to the processor. Now the processor, here's a processor. You could see fitted on the post behind the ear. This is an example on a plastic model. So you could see the ear. The processor is attached to the implant, and that has a battery in it and has the microphone in it, and it's picking up the sound and transferring the sound directly to the cochlea, bypassing all of the ear troubles. Another way to send the bone conduction signal to the inner ear on this side or to the other side in single-sided deafness is through a transcutaneous device, which means there is no post that is poking through the skin to connect to. All of that system that you see on the right side of the image is embedded under the skin. The processor, which is the black device, is outside, and the two attached to each other, magnet to magnet. So this is a magnet type of a device instead of a clip kind of a device that we saw in the previous slide. So there's no skin penetration with this, which means you have less risk of getting inflammation of the skin and infection if bacteria sneak in there. All of these procedures are minimally invasive. It's very short and very quick procedure. And what we call them minimally invasive. So we do it under local anesthesia. The problem with this particular model, which is the magnet model, is that in today's technology, it is not MRI compatible. So if we feel that somebody needs MRIs of their head on a regular basis, we prefer to do the Connect, which is that small clip that you saw earlier. That is MRI safe because it does not have a magnet. It connects with like a stamp. The ones that need a magnet interferes with the MRI. So if we are doing it for a case, for instance, if you had an acoustic neuroma, which is a tumor of the hearing nerve on that side, we do not use the magnets because we want to monitor that neuroma with MRIs over time, and therefore we would prefer the Connect. So in this slide, you see the internal component, which is to the right side with that silver thing. At the bottom of it is the little magnet. And on the left side of the slide, you see the different colors of the processor that attaches, again, to the side of the head. And it would look like this. This looks huge because it's magnified. It's not as big as you would see it on this picture. And of course, everything is covered by hair. Another option when you have hearing loss that is more significant than the hearing aids can handle is called the Earlens. This is a completely different thing than bone conduction devices. This is a device that replaces a hearing aid. It's called an Earlens because of the analogy with the contact lens for vision. What you see on the bottom right is the lens. That lens sits on the eardrum. It has a micro electronic circuit in it, which communicates with the outer device that looks like a regular hearing aid device, but it isn't. So this device now is sending electromagnetic waves. It sits in the ear canal just like a regular hearing aid, and it sends those waves to the lens that is sitting on the eardrum, creating a more powerful wave of stimulation, more than a hearing aid can do. Hearing aids work with volume. So for you to hear louder, the hearing aid is giving you more volume. But as the hearing loss worsens and you need more and more volume, you get more distortion with loudness. You get more feedback. You get more buzzing and ringing. This system gives you the stronger stimulus without distortion, without feedback. And the other benefit of this system is that it stimulates a wider frequency range than a regular hearing aid. So in this slide, you see in the upper line showing you the wide range of frequencies that the inner ear can accept. So you have from very low frequency on the left to very high frequency on the right, and the normal ear can hear from very low bass to very high pitch treble and high-pitched noise. That's how the ear is programmed. A conventional hearing aid cannot cover this wide range, and the line in the middle shows you the limited range of conventional hearing aids. So if you wanted to hear more low frequency sound, more bass sounds, which gives you the richness of sound, or if you wanted to hear more high-pitched sounds, which gives you a better recognition of the consonants in speech, then this Earlens system, which you see the representation at the bottom line, is able to give you more lows and more highs, wider than a conventional hearing aid. Not as good as the normal ear. There's nothing as good as the normal ear, but much better than what a conventional hearing aid does. So this is called they call it the speech banana because it kind of looks like a banana. But what I'm showing you there is the different syllables and how some are located in the low frequency range and others in the high frequency range. And if you're not stimulating properly the high frequencies, you will hear people talk to you, but you don't understand what they're saying because you're missing the consonants. You hear the vowels, you don't hear the consonants. Particularly if people talk to you from a different room, or if the TV is going, or if there's any background noise going, the dishwasher is going, multiple speakers, restaurants, parties, you need a good representation of all frequencies. And that's what this system does for you. The next kind of implants that I will cover now is called the cochlear implants. Cochlear implants are becoming more and more familiar. And it used to be a unique thing to certain people. Now people walk off the street, they say, I want to know whether I'm a candidate for a cochlear implant. Why? Because they've heard about it. Why? Because they have tried and used hearing aids. And now after their fifth and sixth pair, the audiologist or the hearing aid dispenser is telling them there's not much I can do. Maybe you are a candidate for an implant. So that's when we discuss candidacy for a cochlear implant. Cochlear implants are approved by Medicare and all insurance third-party payers. Only the cases of single-sided deafness, which means deaf on one side but good hearing on the other, Medicare does not cover implants for those. Medicare needs you to be deaf on both sides to pay for the cochlear implant. If you're only deaf on one side, Medicare will pay for the bone conduction implant, but not for the cochlear implant. This is a cochlear implant. So all of this is implanted under the skin with the wire that you see at the bottom that ends with something that looks like a snail, and that is the cochlea. This is what the cochlea looks like. And surgically, we place this under the skin and we thread this wire and this cochlea inside the inner ear. Now, inside this little tubing are multiple channels, multiple electrodes that are going to stimulate different parts of the cochlea. The basal part of the cochlea, which is the beginning of the curve, the basal part stimulates the high pitches, and as you go to the tip of the cochlea, that's where the low pitches are. So the processor and this implant are going to take the sound coming into the ear, is going to transmit it through these electrodes and stimulate the nerve endings inside the cochlea differently according to the different frequencies of the words that you're hearing or of the sounds that you're hearing. So that is the internal part. The outer part looks either like a hook over the ear, like that, with a magnet. Again, that magnet you see above the ear, and in a normal situation, this is a plastic model, In a normal situation, it sits a little bit behind where you see it now, behind the ear. Again, it's in the hairline, it's covered by hair, and it transmits the sound, the microphone picks up the sound, sends it through that rounded structure, through a magnet to the internal structure. Internal structure leads it into the cochlea. It stimulates the cochlea, it stimulates the nerve, and the nerve sends the information to your brain. As long as the brain is working well, the cochlear implants work. As long as you have enough nerve cells inside the cochlea, the implant will work. Cases where the implants do not work is when the ear has not been stimulated for a long time. You know, somebody who was born deaf, who's never heard, has never used a hearing aid, comes to me at the age of 45 and says, I want a cochlear implant. I'm going to say, you know, you're not going to do well with the implant because that ear and that part of the brain has not been stimulated properly, regularly. So we could send in the information to the brain. The brain doesn't know what to do with it. So continuous hearing stimulation is important for a cochlear implant to eventually work better and for the brain to continue to work well. Unfortunately, people wait too long. The average waiting time, based on research, for people who have known that they need a cochlear implant until they get one is about 5 years. Because they feel they're not ready for it, or because they're nervous about it, because they're afraid of it. Or because they just procrastinate. I have people who argue, you know, I hear what I want to hear. I don't care about what I don't hear. You know, it's a lifestyle decision. There are people who want their implant immediately because they cannot stand it. They cannot stand the fact that they cannot communicate and hear. So it's important for all of us and for society to have people hear and communicate, because in a study that was done by the government, they defined hearing impairment as not only a problem of an individual, but it is a societal problem. It's a problem with the family. It's a problem with society. It's a problem with income generation. So it's not just an individualistic issue. This is another version of what a cochlear implant would look like. And in this one, there is no hook around the ear. There is no nothing that goes inside the ear canal. Everything is in that little circle, and it has the magnet and it has all of the devices in it, and that attaches again through an intact skin to the internal magnet, which is embedded surgically. They both work the same way. There are some people who prefer to have just a single unit like this versus the 2 units that you saw in the previous slide. It's a matter of preference. You could have both. Most of the time when we implant, you get 2 processors because one could break and you have another, and you could choose to have one of this style and the other on the other style if you want to do that. That's possible as well. So what I want to conclude with here is that hearing loss affects the quality of life, social interactions, motor skills, psychological aspects, and function and morphology in specific brain areas. It's not just an ear issue, it's a brain issue as well. Long-term hearing deprivation can impact cognitive performance by decreasing the quality of communication, leading to social isolation. We see that all the time. People don't want to socialize. They don't want to go and visit. They don't want to go and have dinner with people because they say, I cannot understand what is being said. I feel silly. I respond the wrong way, and so on. So having a good hearing is important for social integration. Not having good hearing leads to depression and facilitates in the development of dementia. We know from studies and research that we've done, and others have published as well, that effective intervention with either hearing aids, implants, cochlear implants may improve, and in most cases does improve, the social and emotional function, the communication skills, the cognitive function, and the quality of life. So, in summary, hearing is important for us and for people around us. Hearing aids are the first level of dealing with hearing loss. If you have mild to moderate hearing aids, mild to moderate hearing loss, then the hearing aid is the answer. If you go into the severe to profound hearing loss, or if the ear canal cannot accept a hearing aid because it's closed or because it's scarred, or because hearing aids are causing a lot of infections and drainage, that's when the bone conduction devices come into play. If you have single-sided deafness, you don't want to live your life hearing from only one side of your head. We were born, designed to hear from both sides. So single-sided deafness is an impact to your hearing abilities. And that you could solve with either the bone conduction implant, or Baha implant, or a cochlear implant, if you are not in the Medicare field. This was a quick review of what's available beyond hearing aids. Now, I have a few minutes to answer some questions. Are we able to hear the questions here, or are they texting them?
They're messaging them, but we can ask them via.
Okay. Do you have something messaged already?
Yeah.
Okay.
Irina is asking about post-COVID hearing loss.
Okay, we have a question about post-COVID hearing loss.
You know, unmute and say that.
Yeah.
So.
Well, I mean, if we have the question, we'll just answer it.
Yeah.
So it is very rare. We've seen a couple of cases where people have developed COVID who came back and says, I feel that my hearing has been reduced since the infection. It's very rare, and it is not, we don't have enough cases to say without the shadow of the doubt that there is a causal effect. Because if you take, normal population of 100,000 people, you're going to have people who are going to lose their hearing suddenly. It's called sudden deafness. You wake up one day and you lose your hearing. Now, sudden deafness is also viral. So viruses can cause sudden deafness. So COVID, as another kind of a virus, could cause sudden deafness. And if that's the case, then we will treat it like we treat sudden deafness. We treat it with steroids first. If that doesn't work, then we go to the bone conduction implant or to the cochlear implant. Because when you have sudden deafness of that severity, where the hearing aids are not enough, then the hearing aid would be a waste of your money, and then you need the implants for that. Do we have another question?
There are no more questions.
Okay, is anybody on the line who wants to ask a question? Unmute yourself and shoot.
There are no more, and if somebody thinks of something, they can email us, and I will put the email in the chat.
Okay, I don't hear anybody, but if somebody wants to email or text or chat.
Email, they can email us, and I will be also sharing the video and emailing that out as well when this is complete.
Okay, so how do they connect with us? Because I don't hear anybody talking.
Everybody's on mute.
Everybody's on mute?
Everybody's on mute in their video. Some people have their video on, but what I will be doing is how they've been getting all their communications with us.
Does anybody have a question?
Oh,
Unmute.
We do. The difference between cochlear versus conduction. Do cochlear implants always work for everyone? That's another one. So we have two questions.
Okay, let's give me the first question.
Difference between cochlear versus conduction.
Okay, so a conductive hearing loss is a hearing loss that is due to a problem within the middle ear, the eardrum, the ear canal, where sound is unable to reach inside the cochlea. The cochlea is where sound is being transmitted to the nerve. That's the inner ear. And the cochlea, the inner ear, will cause a nerve loss, a sensory neural hearing loss, if that should happen. So people who have hearing loss from aging, for instance, that is called a sensory neural hearing loss. That's from a deficit within the cochlea or within the nerve. This is not conductive. And that's the most common type of hearing loss, which is the hearing loss that we get as we get older. That's cochlear or neural. Conductive is due to specific disorders of the eardrum, the middle ear, trauma, infection that cause dissolution of the bones of hearing. That causes conductive hearing loss. Conductive hearing loss is potentially fixable surgically, so you don't need a hearing aid or hearing device. What was the other question?
The next question is, do cochlear implants always work for everyone?
Do cochlear implants always work for everyone? There's never always and never, never. So in general, they work. In the vast majority of cases, cochlear implants work. And before you get a cochlear implant, you are evaluated for candidacy for a cochlear implant. We have to know ahead of time, before we implant, how are you performing under the best aided condition? And the best aided condition is fitted with the appropriate hearing aid, and you are tested with your hearing aid in quiet and with background noise, and we record your level of word recognition. So we're not going to put a cochlear implant in someone who's doing well with the hearing aid. The Medicare criteria and the insurance criteria and the manufacturer's criteria need you to be hearing less than 40% for Medicare, 50% in private insurance, in the best aided condition for you to qualify for a hearing, for a cochlear implant. So if you're doing better than that, you're not a candidate for a cochlear implant. So now we have to compare the people who are worse than that, who are doing less than 40% speech recognition with their hearing aids, to how they do with the cochlear implants. And the vast majority of people do much better with the cochlear implant. So you go from being 20% word recognition to being 60 or 80% word recognition. And that's a big difference. So the majority of people who get cochlear implants, done properly and done without much delay in the time of deafness, do well and are happy with their implant. Any other questions we have?
Are there any side effects to cochlear implants?
Side effects to cochlear implants. A cochlear implant is surgery. It's not brain surgery, it's ear surgery. An incision is made behind the ear, and the implant is inserted through the mastoid area. Anytime there's an incision, there's a chance that there's infection. So infection could be a possible post-operative complication. Fortunately, people are treated with antibiotics before, during, and after. So we rarely see infections because everybody is covered properly and surgery is done in a very sterile environment. Dizziness can occur after cochlear implant surgery. Dizziness can occur after any kind of ear surgery because the inner ear also is a center of balance. And when we open the inner ear to place the electrode, the center of balance could get upset and you could get dizzy for a couple of days, maybe for a week, and then it gets better and better after that. So dizziness is a known reversible kind of a complication, if you will, or occurrence after a cochlear implant. We often attempt what's called hearing preservation when we put a cochlear implant, which means we want to preserve the level of hearing that is natural in the ear as we place the cochlear implant. And the reason we want to do that is because it gives us better results with the implant and preserves the hearing so that that ear can still hear even with the implant being off. Of course, the hearing is not good because the whole reason of doing the implants because the hearing is not good, but at least it doesn't go to zero. However, if the hearing loss is significant in some people, no matter what we do, the inner ear shuts down, which means the natural hearing without the implant is gone, and you can only hear with the implant. Again, that is not a problem in most people because if that hearing was adequate, we wouldn't be doing the implant to begin with. Anytime we do ear surgery, we say there's a risk of facial nerve injury because the facial nerve runs through the ear. We say that because it's a risk. The risk of having a facial nerve weakness after a cochlear implant is extremely rare. I personally have never seen it, and I've been doing implants for 30, 40 years. So it's a rare complication, but we tell you about it just maybe to be complete in our education. One other rare complication of a cochlear implant, which we haven't seen recently for at least a decade now, is meningitis. And meningitis occurs because bacteria could travel through the implant into the nerve area and then into the brain area and can cause meningitis. And that's why now, since that happened in a few cases a few years ago, probably 20 years ago, the CDC recommends that patients who are to get a cochlear implant get a vaccine for meningitis. It's the pneumonia vaccine because it's the same bacteria. So it's called the Pneumovax and the Prevnar vaccines. These are pneumonia vaccines that most of us over 65 are going to get anyway for pneumonia prevention. But if you're getting a cochlear implant, we're going to ask for that vaccine before surgery. I personally have not seen any case of meningitis in my patient population. Neither have I seen any facial nerve. I've seen some cases of dizziness that respond, and the performance of the implant and the benefit from the implant far outweighs any of those risks. Any last question, Christina?
May I ask a question?
Oh, we have a live person, yeah.
I have a good friend who really needs to see the recording of this, and I wondered when it would be available so that I could maybe send him the link.
It will be emailed out to everybody that participated today. I hope to have it completed within a week.
Okay, thank you.
You're welcome.
Well, I thank you all for your interest. I hope I have shed some light. I have covered a lot of tools and techniques here. Each one of them could take multiple hours of lecturing on, but that was not the purpose today. The purpose today is to open your eyes and ears on what's available when the hearing aids are not the final solution. So thanks for your attention. And you could email us for questions. I'll be happy to answer them. And as Christina said, she will email you the link for this performance, this lecture, educational session that you could share with friends of yours.
Thank you,
Okay.
Dr. Wazen.
Thank you very much. It was excellent. Thank you.
You're welcome. My pleasure.
Okay.
Thank you, Dr. Wazen. Okay.